Can someone out there in Zoom land tell me if they can see me and hear me?
I can see you and hear you.
Terrific. Thank you.
Enthusiasm, please.
Thank you very much. All right. So for those of you who don't know me, I'm Mark Zucker. I'm one of your general pediatricians here at CHEO, and I have great honor today to introduce our speaker, Sunny Denani. Before we get there, we'd just like to do the land acknowledgement. So Ottawa is built on unceded Algonquin Anishinaabe territory. Peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. The culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So I don't know if Sunny needs a huge introduction because many of us know him. He is the former Division Chief of Pediatric Critical Care at CHEO. He's now the Ontario Health Lead for Pediatric Critical Care. He is the chair of the Canadian Donation Physicians Network, Canadian Blood Services. He is the Associate Director for the Canadian Donation and Transplant Research Program. Now, before I get on to introducing Sunny up here to start talking to you, I also wanted to use this opportunity to let you know a special announcement today about Sunny. So many of you know Sunny took a sabbatical about a year ago, and what you may not know is Sunny is actually an avid sailor. And he will be embarking this summer on a circumnavigation sail around the world solo, looking to break the world record of 42 days and 2 hours. So he spent actually his sabbatical doing intensive training in Vancouver, and we're looking forward to seeing how he does. So today's the announcement of that for the CHEO population. If you'd like to follow him on his Instagram page, you can look up Sail with Sunny D. And if you're not sure, you can also hashtag This Ain't Kool-Aid. So with that, I would like to bring Sunny up for his presentation, Organ Donation Building Trust in Our Hospitals, Our Community, Our Future. Thanks, Sunny.
Thanks, Mark, for that great welcome. I'm assuming you can see me. Real honor, one, for that launch. Get it? The boat launch? The launch. And so we can, no, that's real.
Oh, wow.
Yeah.
Was it Lily inside too?
Yeah, absolutely. It gets, 42 days. She wanted me to sail longer. I have the pleasure of also kicking off Organ Donation Month. And part of this talk is threefold. One is I want you guys to appreciate CHEO's impact. It feels that organ donation transplant may be more of a critical care focus, but in fact, that's all of us that have a part in this, that recognize in an era of mistrust that there are certain things that in donation and transplantation lead to mistrust. But my hope is that with science and community engagement, we can build that trust. So we'll walk through that in the next 45 minutes. So we have to engage that. Some declarations is I have some leadership roles with a number of organ donation and transplant organizations, including Ontario Health, which was mentioned already. I'm going to tell you about something called Donation Advisor, which I have a patent, but I don't have any company holdings. Little bit of context here in Ontario, there are almost 1,700 individuals waiting for a transplant. I think to note from this slide, the first category, under 18, it sounds like not very many, only about 30. But in fact, these are our patients on dialysis or in heart failure or hanging out on the wards in liver disease. These are our patients. We only have 4 hospitals. These are our sickest patients waiting for life-saving transplants. 1 person dies every 3 days. And because of the nature and severity of illness, these are actually disproportionate to that under 17 group. The other thing I note is there are people on the waiting list above 70. So half of us in the room can still get our transplant when we need it. That's amazing. What we're going to talk about a little bit is we feel that trust has been eroded because there's lack of information from the donation transplant system and death and dying in general. And in fact, one of these misperceptions is that if we sign our donor card and we die, we'll get to be a donor. But in fact, being a donor is really hard. You have to have very specific circumstances of dying with specific injuries so that the rest of your organs are still functional, dying in an ICU, being placed on a ventilator, recovering most of your hemodynamics, and then being assessed for donation. That is really rare. Less than 3% of deaths in Ontario are actually eligible to be a donor. This is a very heartbreaking quote from two colleagues of mine, nursing researchers, when they talked to a coordinator who deals with donation. He said, I think it's a double loss for the family. They're losing their loved one, and then they don't get to donate. Right now, we can't predict who can be a donor and who can't. And so we're going to talk about some of the science of that. But before I get there, how does donation work in general? There are a number of different players: the ICU teams, donation docs, the organ donation organization, which is Trillium Gift of Life, the transplant teams, and then coordinators who coordinate that on the donation side. You have to have a life-limiting illness where there's no hope for recovery. Only then do you fill criteria to get a call to Trillium Gift of Life. You have to either be primarily brain dead or have circulatory death that leads to brain death to then be eligible to be an organ donor and a transplant. And then those organs have to be suitable to be transplanted. So in fact, that's where all the complexity lies. You can have both lungs transplanted separately. The heart can be transplanted, the small bowel and pancreas, the liver, in fact, can be split into two, and then the kidneys can be individually or en bloc transplanted. Then we have tissue, which is corneas, that looks like bacon, but it's bone, and skin. Now, the Trillium Gift of Life Network is our organ donation organization across Ontario. Each province has their own. So even though we think we have a national health system, in fact, organ donation is fragmented. So every province does it differently. We are lucky in Ontario, in fact, that we have a law that guides organ donation. Not so in every province yet. Hospitals are required to report all deaths, not after death, but prior to, when there's imminent death. And that gives us the opportunity to fulfill donation wishes, that we all have to have the same policies and procedures, pediatrics to a geriatric center, to have the same practice and procedures, standardization, health, that ODOs like Trillium have access to personal health information automatically. They are part of our circle of care, which is actually really rare in our era. And lastly, that hospitals have to approach families with the opportunity to donate. It's not a physician choice. It's not a hospital choice that we, by law, have to approach. Now, the timing of the approach is what becomes tricky. But in fact, if we go back to the green one where the policies are all the same, then we approach families after there's no hope for recovery, and we've told families that. And so right away, Trillium gets to be approached. So how did we do? Over the last 5 years, we notified all deaths. Actually, we've missed one or two over that time, and very few don't get approached. And there's really reasonable reasons not to do that. But in fact, almost all these situations have been approached. Most families consent when they're approached, and we actually had 10 donors. Now, we're very fortunate, actually, right? Our ICU mortality is about 2%. So that's the context. You're like, well, 10 is not very many. But in fact, we don't have very many deaths, thankfully, because of excellent ICU care, I'd say. From there, 37 lives were saved. These are 37 lives that would have been dead. 9 heart transplants, kidney transplants, 3 double lungs, livers. Those are often really infants, right? With biliary atresia, and pancreas and gut. 37 lives. Easy. Actually, the last few months have been very hard on the ICU with a number of deaths, and we actually had 3 donors just in the last 2 months. But from those 3 donors, 15 lives were saved just in 2026, just from CHEO. We rank fairly nicely with the rest of the province, but what I will say here out loud is that we do way better than some of the bigger hospitals that you think would be, down south that would be more slick at this. In fact, the smaller hospitals, London, Hamilton, and CHEO, actually pull above their weight when it comes to impact on donation. What happens here is because of a number of different factors. One, we have an amazing committee that has worked together with a number of different players from social work. I'll shout out Danny Sutton-Long, who's our TGLN coordinator. Roger Nielsen's house has Chris Vadebonker, who won an award herself for donation last year. And we continue to win provincial awards. This year's award was for the eligible approach rate. So every family who had a child who could have been a donor, we approached 100% of the time. That's all we can do. That's our job, nothing more, nothing less. And because we've done that over and over again, CHEO received an award of excellence. This is the OR team to highlight that it's not just one individual. It's the whole hospital, from the ER to the wards to RNH and our palliative care team to the OR, the NICU and the PICU. I want to move on now that we have a baseline of this idea of trust. And I think the idea, that we have to, write, the fact that we have to write articles to say this is a trustworthy system worries me. It means that there's a pervasive understanding that something is going on. And it's not just the donation and transplant system. What it actually is the medical system and how we operate in dying situations and how we operate in death situations. So when we look at this, every single figure here has an element of mistrust. The first one being we don't approach people until there's no hope for recovery. The idea that we go to the nth degree for life-saving measures, that's what people are worried about. That if they sign their donor card, and we know that as they come into an ICU or an emergency department, that we may not pull out all the stops to save their lives, which we know is not true. But how do we put systems in place to make sure that's clear? For me, we've had a lot of distrust around the determination of death. And one of the fundamental principles for organ donation is you must be dead for organs to be recovered. It seems simple and trivial, but in fact it's a primary tenet for us. But we realized that actually everyone was determining death in various ways. And so over the last couple of years, we have now really finalized with research how we define circulatory death and how we confine brain death. And so we feel more strongly that when we get to the point of donation, that people are 100% dead. There's two ways of determining death: determination by circulatory criteria or neurologic criteria, brain death. And one of the areas that has become an area of mistrust is donation after circulatory death. ICU admission, poor prognosis, we make a decision that there's no hope for recovery and that we're going to withdraw life-sustaining therapies. They're not brain death. They go forward with consent to donation, and then we remove life-sustaining therapies, and the dying process starts. We take off the ventilator, we take off the pressors. What then happens is this variable time of dying. It can be within minutes, it can be within hours, it can be with days. We don't know. Everyone becomes a donor. So a family who consents says, listen, I'm ready to be a donor. And then we get to this extended period of time. And what's happening during that extended period of time? Those organs are also not receiving blood flow. So about the 2-hour mark, the kidney's not transplantable. 3-hour mark, the lungs. The half-hour mark, the liver. We're done. What happens then? They don't become a donor. There is lots of evidence. In fact, Christina Krompatek, one of our fellows, wrote a nice article that 30% of the time when people consent to donation in that scenario, they don't get to be a donor. And remember that first quote about that double hit. They said, yes, I want to be a donor. They go through this entire process, which sometimes takes 2 or 3 days, extending the dying process to be a donor, and then they don't get to be a donor. There's a cost to this. In fact, in many jurisdictions, they just say, listen, I don't think that person's going to die in time. We're not going to even offer donation. The transplant team from Toronto says, I'm not going to go to North Bay because I don't think that individual's a die. You can't spend $30,000 to fly us all up, wait 2 hours in an operating room, and that individual doesn't die because I can't put that soft organ into my transplant recipient. We, in Ontario, try to attempt almost every time. But that's costly to the system if 30% of the time there isn't a donor. Not efficient, but most importantly, it's hard on families. It's hard on families and the healthcare team and the organ donation coordinator because we've all invested time and energy into this. The inability to predict which patients will be a donor is not okay. It's inefficient and harmful to families. So we embarked on a mission to try to predict time to death. Though it sounds ghastly, we could see the benefits of this. And what we realized with scoping reviews is actually there weren't any existing prediction tools that were sensitive enough. New tools are always emerging that are simple. 3 or 4 things: corneal reflex, cough, GSCS motor, and how the individual oxygenates gives you a clue of whether they're going to die within that 2-hour mark. But in fact, the way we validate some of these scoring is called the ROC AUC, and they aren't high enough, showing not sensitive enough. And just briefly, this summarizes how well a prediction model separates kind of a true positive and negatives based on lots of factors. If you're 1, you get it right every time. If it's a 0.5 score, it's 50-50. And that's where we've operated, in the 50-50 range. An individual looks at a patient and says, I don't think they're going to die. Or, yeah, for sure going to die. And we get it wrong all the time. So we probably want to get to somewhere in the 0.9 range. And that last one was 0.8. Now, we've always tried to simplify decision aids to help us. But now with AI and machine learning, we can turn up the complexity here. We don't have to be afraid. We've always used statistics, but in fact, when we use predictive modeling, we can handle larger data sets. We can derive the models and then continuously validate them. And so we're in a whole new era to shift between statistics to predictive modeling using machine learning. And this is where we think the science needs to build trust. So the question is not, can we use AI to help us? It's how do we best do this in this environment? That instead of choosing fewer factors, we've decided to use more factors. Factors that vary over time and location and individual practice. And we hope that we could now objectify this more subjective area that creates mistrust. We created a tool called Donation Advisor, which we have the patent, that we could collect the data, okay, including something new. Real-time waveform vital sign monitoring. Can you imagine how much data that is? These aren't just individual data points of the blood pressure was 90/60. This is beat-to-beat physiologic variation. To predict the time to death before withdrawal life-sustaining measures at 30 minutes, 60 minutes, and 120 minutes, relevant to those specific organs. And also after withdrawal is started, that we can continue this modeling, which we can repeat every 5 minutes, to then tell those transplant surgeons who are now waiting, getting close to that 2-hour mark, to say, no, we say that actually it's 0.99 likelihood that they're going to die in the next 5 minutes. Stay. How helpful is that? Where right now, they just use the clock. 2 hours, gloves off, and they walk away. We did have an individual who died at 2 hours and 5 minutes here and was not able to be a donor. This all started when we did the DEPART study looking at how individuals die in adult ICUs. And we monitored their blood pressure and heart rates after they were determined dead. That was our primary objective. But what we realized is that we had a lot of information. We had 20 sites, over 600 patients, adults. Did take 13 years of my life. What we had is all this rich data, which at first we wanted to put away, but with machine learning, we could bring all that data in. That we had this untapped resource of how physiology works, not just clinical parameters. And Andrew Seeley has a lab at the Ottawa Hospital, a research institute, and their lab has been doing this sort of science to predict sepsis, to predict extubation failure, and we thought there was a signal here when we used the 631 patients to derive and then validate a model. Now it's not just the rates, it's the variability. Now this is not new to us. We've been doing this for fetal medicine for generations. When you're ready to deliver and the fetus has some D cells, it's just not going down. It's the variability that gets us. If it goes down, fine. If it doesn't come back, that's what we're worried about. Why wouldn't this work for us? Everyone's got their smartwatches now, and we get actually our HRV documented this every night because it works for us. There is a signal here that based on sympathetic and parasympathetic nervous system, that variations in heart rates, blood pressures, respiratory rates tell us if our body is stressed. And the premise here is if there is low variability, that your system is not functioning well, probably directly related to brain injury, that you will die faster. That's a lot of data. So we said we'll take the clinical features, but not just one or two. Let's take all of the ones that have shown a signal. Neurologic, lactates, how we withdraw, whether we intubate or just turn down the ventilator, extubate or turn down the ventilator, whether we stop the pressors right away or gradually wean them, what drugs they're on, morphine or midazolam, and what those patients look like, how big they are, how old they are. Then we added the vital sign variability. Heart rate mainly, but also blood pressure. Saturations aren't well measured at low levels, so we took that out. And we kept in clinical prediction, which traditionally has been 50-50. We get it wrong all the time. But in fact, what we realized is that we were trying to simplify it. If we take all these factors, clinician prediction is actually better and better. Only now can we bring all that together and then calibrate those probabilities of death after withdrawal in tight margins. And then deliver it to clinicians, the ODO and the transplant teams, and potentially families of confidence of what time frame they're going to die. And this may have more relevance to us in pediatrics without donation. To tell families, this is going to happen today, this is going to happen within an hour. It's very simple for us to add this waveform variability. We plug our software and laptop into the monitor, and all the rest of the information is already collected by the organ donation organization to assess for transplant. We embed ourselves into the donation process after they get consent. That right now we're doing this in a study format, and we plug in our computer with family's consent. And our consent rates are very high for this sort of research, above 90%. Then withdrawal of life-sustaining measures is initiated, the individual is extubated, and then we continue monitoring those vital signs and report to the transplant teams up to every 5 minutes of how quickly we think this individual is going to die. And notably, as you get closer to death, our numbers get better, right? You're more able to predict. So we decided to separate individuals into categories to make it easier to digest that information. Low likelihood, a medium likelihood, and a high likelihood of death. In fact, we feel clinicians are pretty good at the high range, and we're pretty good at the low range. So it's really this middle tertile that's super important to us, right? So that we don't go ahead with donations that are unlikely to die, but we also don't want to miss donations that should go forward and people don't want to go forward with it. Now our initial AUCs were 0.86. We now touching 0.9 as we continue to validate that. And remember, after withdrawal, we continue to do the same process in real time. And like I said, our RSEs tend to get higher and higher, reaching that 0.9 threshold. This is what the clinicians see, the organ donation organization sees, a probability of death within 30 minutes, within an hour, within 2 hours. We separated it out so that physicians and the team could look at the clinician prediction, the traditional clinical model, and then adding in the variability. And we did that because there's a mistrust with AI. People are uncomfortable letting something else make this decision for them. So we showed them the impact of what heart rate variability could do for them. This is the real-time graph for the transplant teams after withdrawal. The green says there's no ischemia. The left is blood pressure, as an example. Right down to at minute 40, there's severe ischemia. Now, this can be very different for two different patients at that 40-minute mark. It can be green the whole time, and then just 5 minutes of severe ischemia, or that blood pressure can drop very quickly, and you could have the whole 50 minutes being ischemic. That's very helpful to a transplant team to say, listen, we've waited long enough. It's no point waiting another 10 minutes. We are going to stand down now. Now they have some objective evidence to make their traditionally subjective, which is not necessarily wrong, but subjective decision. We did a feasibility and evaluation study of the tool in 4 Ontario sites, again, adult hospitals, where we assessed 27 donors. We were able to deploy the tool 100% of the time. And in fact, retrospectively, we were right in our probability markers 100% of the time. We interviewed the clinicians who worked with that patient, but didn't see the tool in real time. We went back to them within the week and said, if you had this, would this be helpful? 83% said it was useful. Where is this 17%? I think it was in those cases where it was obvious that they were all like, no, I knew this anyways, right? So in fact, 83% is pretty good, much higher than I thought. And we actually used this evaluation project to change the tool. And it was the people at the bedside and in the OR who said, no, we don't need, in one of the examples, we don't need 12 pages. Give us 1 page that tells us the meat. And we gave it to them. Here are some more qualitative comments. And in fact, on the bottom, it was the surgeons. This is going to be really important for us because this functional ischemic time, this time after withdrawal of life-sustaining therapies, is so important for us when we go to make a decision to put it into our real transplant recipient. This is real for them, right? We want them to be donors at all costs on our side, but in fact, the transplant recipients need to be accountable to their recipients. You can't go through this procedure and then that organ fails. And I think it was highlighted, which I was really thankful, that for the families and their expectations, and I'll add in the healthcare team, this is going to be super helpful. We have a huge team in Canada, and in fact, where we've seen a lot of interest is in other places that do organ donation a little better than us. They're 10 years ahead of us, places in the States, like Philadelphia and the UK. Our systems are very similar to the UK, and their stand down rate for these type of organ donations is still 30 to 50%. Right now, we're embarking and been funded for a 4-center feasibility study. So this is actually putting the decision aid into practice. So it could change decisions in real time. We're working with our partners, Trillium Gift of Life. They're very supportive. Where we're stuck now is now that we're going to implement it and put it into practice, we need Health Canada approval as a medical device. And that's been very challenging. So we're waiting for that approval before we can actually go further. Many of you, the first question will be, well, why aren't you doing this in peds, Sunny? You're a pediatrician. We actually did 8 to 10 patients from the DPART study, which we didn't publish, but in fact we need a bigger cohort. And the problem is that you don't have a lot of pediatric deaths. Julia St. Louis is our PhD researcher out of SickKids. She's a nurse there, and she is now embarking on her PhD to start collecting data at SickKids retrospectively. And in fact, they have an embedded monitoring system called T3, where they have these waveforms over the last 5 to 10 years. So it's going to be an exciting part to now include studying pediatrics tool. And it may be different. You know, their heart rate variability might be quite different than us. So next, I'd like to talk about like how hard this has been to implement a decision aid, you know, and here we're trying to build trust. And it's impossible now to say, you know, let's just use something that looks helpful. We still have to go through our rigor with a randomized controlled trial. But it's hard to do that versus standard of care because at the risk of changing a system might add to mistrust. What do we do when we get it wrong? Now, decisions by individuals and transplant teams get it wrong all the time. But what if our decision aid owns that decision now? How are we going to deal with that? I talked about health regulation. And in fact, funding is hard. It's hard to talk about a small group of healthcare individuals when you're comparing it to genetics and cancers. And I'll call out Roger, concussion. These are big deal, more common events. But this is a small fraction, impactful, but a small fraction. And are we prepared to go to non-traditional funding companies, for example, commercialization, to try to accelerate the needs of our community? But mostly I want to talk about trust in AI. We know, especially in the American system, there is a lot of mistrust around death and dying. And the impact is hard on organ donation, actually. That organ donation transplant rates in the States have gone down significantly. And that's why we published the article here in Canada to say, we don't do things the same way. We have standardization. We have third-party decision makers that protect us from other interests. In the States, a hospital gets paid for every donor and transplant. And so there is an incentive to do more donation transplantation. There's also mistrust in this. You know, I just went from we got all this data to we've got a tool. But in fact, look what goes into that AI machine learning algorithm. This is scary stuff. What are we worried about? Oh, you want to take that? There you go. This is what we're afraid of. AI is this black box that we think we've created, just like Frankenstein, and they're going to come back and attack us. That it's going to be out of control. Notice I use the word they. It will be out of control. That we will lose control to AI itself or somebody who's controlling AI, like the government. We are afraid that actually AI becomes sentient, but sentient without the morality that we all hold to make sure things are fair, equitable, just. And lastly, we're fearing being locked out of the process that we as physicians and healthcare workers value, our connection to patients. And we're going to be left, by the way, for many of you, this is a typewriter and a phone. In fact, I use AI to generate this really excellent list of why we're afraid of AI. And I got a little worried when, before they gave me the list, they asked me, are you human? And I had to say I'm not a robot, which got me thinking, who else is asking this question if it wasn't human? You know, is AI itself asking, how do I break the hurdle in humans? So let's bring it back to our patients and our families. Heather is a mother of a teenage donor years back and works on our project. And Dawn is a heart transplant recipient from Kingston that has worked on our project. This sort of information and project is meaningful to them. So though we're afraid of machine learning and AI, the benefits are going to be to our patients and their families and ourselves. And that's what drives us. This is a quote from Amanda, who is also a researcher here, nursing researcher, social work now, anthropology, now in Toronto. And this was from a family interview. I remember thinking at about 20 minutes before the 2-hour time frame, thinking, no, don't look. Imagine this family's looking at the monitors. Please let the monitors go silent. It was just like I was beginning to have, not anxiousness, but this huge disappointment. And I remember when that time came frame, how could this be? Karen's child was not allowed to be a donor. So it's impactful. Here's our team. We think that AI decision aids are going to create a subjective experience to add value, to make it more objective. We hope we can make it simple with this sort of app profile. And what we really want is that the science now can build trust. Build trust with our families, build trust with our hospital community, and build trust in the entire system. So it's not only science that trust is built on, but it's also standardization, which we won't talk about today, but community. We've built a donation physician community, of which I am one here, across the entire country. Even though we have separate health systems and separate organ donation organizations, we have physicians coming together with webinars and standardizations and studies like this to say, hey, does this matter to you? There are almost 250 donor coordinators that work with organizations that also participate in this process. We have, for the last 10, 12 years, a very robust national research organization that brings together donation scientists, transplant scientists, but more importantly, trainees and patient, family, and donors. More than 100 of them that then impact and start these questions from ground zero. They're not afterthoughts. We were the first organization, one of the first organizations, to include patient experience into our science. And in fact, when we went to CHEO here, they came to us and said, how did you do it? And I'm very thankful for that in our system. We're also reaching out to the community directly. This is something called the High School Outreach Initiative. And the mission is actually to convey the importance of organ donation and transplantation to the youth. Now, I remember when I was young, they came to talk to us about drinking and driving. And in fact, it was me who talked to my dad and said, listen, I think you've had enough to drink. Not okay to keep driving. We did the same thing with seatbelts. Probably our kids shamed us out of smoking. These are all things that kids and youth have an impact on their adults. And we think this is an opportunity, especially because kids are now going and having to get their driver's license. I've got one without information. So we're targeting high school students between 15 and 19. This started in the Toronto area, and our goal is not to get them to sign their donor card, yes. Our goal is to educate them so that they can make an informed decision. It really is important. Now, it's been going on in Toronto for many years, with almost 1,000 presentations and tens of thousands of students who have been impacted. And 3 years ago, we decided to start this in Ottawa. And you can see we have fewer high schools that have engaged us. It's about an hour presentation to an hour and a half, and we have a tag team, a healthcare professional, and then someone who's been impacted by donation and transplant, either a family member, a living donor, or a transplant recipient. And it's really interesting who the healthcare professionals are. They're not just physicians. We've got trainees, we've got nurses, we've got physios, we've got pharmacists. It's really an interesting group that has come together to advocate for donation. We've done really well over the last 3 years, that we've seen a rapid growth where we had 7 presentations, now up to 25, that we've got almost 1,000 students that were impacted, almost 1,200 last year. And so far this year, we're already probably going to project well above that. So we're really proud. What it tells me is that there is a need, there's engagement, and there's enthusiasm to talk about this. Where at first we were afraid that this was a taboo subject. We were afraid that we were going to get letters from parents, why are you talking about death and dying? But in fact, these kids are really, really engaged. I think 80% highly engaged is pretty impressive. We've noticed that kids in this age group don't bring out their cell phones when we're talking to them. They are listening the whole time. And the 30 minutes we have for questions are really special. Like they're really high level. They've done their biology units and they're really thinking outside the box on some of the medical issues and the ethical issues. And we haven't done a before or after, and these are actually low numbers of recipient for our N for this sort of numbers. But I think we're getting the signal that these kids and teens are talking to their families, which is all we wanted them to do. We've got a big team mostly in Toronto, but Rob Mayette is the co-lead here, and Joanne Lynch is our program director. And really, I'd like to thank all the speakers who have signed up so far. If you guys are interested in joining, call me. We have lots of room and enthusiasm, and it's an hour or two of your time that I think you'll find really rewarding. And thankfully, the CHEO itself and the CHEO Research Institute have endorsed this program. And I think if we could make this an official CHEO program going forward, this will be super, super important to us. So what are our take-homes? Is one, CHEO is a strong advocate. Though our overall numbers of donors aren't high, that in fact we've got our policies and procedures and standardization and the team's willing to go forward. We've won awards, but more importantly, dozens of lives saved. That there is potential when we talk about dying, death, and donation for mistrust, and we've seen that in the States, but we definitely feel that trust and then building engagement through science and community will build that trust for sure. Lastly, I put a plug for our hockey game. Logan Boulay was part of the Humboldt Broncos crash a few years ago. A hockey player who ended up being a donor. And so his family has advocated for April 7th, Green Shirt Day. And so we're gonna have a hockey game against the Ottawa Hospital. We've got a CHEO team. We've lost the last year, so we're hoping that with fan support, we will do better this year. So thank you so much for listening. I'm happy to answer questions. We've got lots of time for that. Mark, thank you so much.
I'm going to stop sharing.
Sure.
Oh, stop sharing for me. There we go. Well, thank you, Sunny. Excellent presentation, as always. We will open up the floor now for questions. Those of you online, if you would like to put your hand up so we can see you, that would be great. Easier than the chat, if you wouldn't mind. And then I already have a question here from Roger Zemek.
So, Sunny, tremendous work. And I know clearly this has been a labor of love for you with all those years of hard work. And I know it seems like the quote from either attributed to Niels Bohr or Yogi Berra.
Yeah.
Prediction is hard, especially about the future.
Right.
A lot of your data that informed your rule was probably based on your massive, highly successful New England Journal study. Going forward, 2026, new metabolomics, microRNAs, are there ways you think you can even leverage even further things that evolve by minute or hour by hour in those maybe fluid biomarkers that could be tech point of care that would inform, and how are you going to refine or revalidate that going forward?
This is a planted question for sure. Do I have to repeat the question?
Yeah, if you wouldn't mind, that'd be good.
So Roger, the summary of the question was, going forward, are there other avenues to add to the prediction model like genetic markers, metabolomics? And in fact, there is. We've got a fantastic collaboration from Vancouver. They are monitoring patients, as we did in the dying process, but taking it to the next level, where in fact these individuals are dying with neurologic probes, EEGs, central nervous system dialysis catheters. So minute by minute, they're able to take samples, not just from blood, but from CSF. And in fact, preliminary studies have shown a signal in one or two biomarkers that in fact are easy to test with a available product. So it's not like you have to create something. So we are now embarking on a co-study to add that value to see if it improves our marker. It might be the single biggest factor, or just add to it, and we're able to add to it. And what it relates to is neurologic cell death. So as the brain becomes more fragile with ischemia, that some of these markers get released only in that situation. Okay? And this is the idea where we've always thought the heart is the core of being alive, but in fact, it's probably the brain. And maybe when we have a cardiac arrest at end of life, it's actually because the brain has told the heart time to stop. And these sort of markers, blowing you away with that, right? It's a huge mind shift that it's not about the heart, it might be about the brain. And what if the brain is sending signals to the heart to say time to stop? And that changes how we might do resuscitation, which is where this work has started. Great question.
I see Jared Sheridan, you have your hand up if you'd like to ask.
Yeah, I'll try to forget that you said that the heart is not the most important, but obviously this is amazing work, really amazing. I'm just curious if you've looked elsewhere in your goal to build trust in the community, such as other nations like Spain, who has a consistent, really excellent record of building trust in the community and getting the word out about transplant. And then lastly, I'm happy to sign up for your program there. That sounds awesome.
Great, outstanding. Yeah, you know what? I've been fortunate to work with Trillium Gift of Life and have kind of these sort of thoughts of how do we do this better. And one of the things we did 10 years ago is we flew to Spain. We flew to Spain, and I spent 3 days with them and said, like, what do you do? I had a whole binder of notes that we then came back. And I think our provincial government especially was very supportive. And we created what they did. We created donation physician. We created standardized systems through every hospital. All 60 hospitals in Ontario do donation the same way, publicly reporting their metrics. They really developed the culture of donation and transplantation for end of life. I think in Ontario we've done that as well, but not across Canada. So now our job now is to do this nationally. And we've created with Health Canada a collaborative, which is now in implementation phase of creating a system from the top to standardize process and add money to the system, not just for clinical guidelines and practice, to support donation networks as well as research. And so that's the phase we are to try to get closer to the Spanish model. Yeah.
Maybe I'll take the moderator privilege of asking a question. So I was interested, Sunny, and you mentioned patient partners in the research. And I was curious if you could expand a bit on that and the roles they play, the responsibilities they have in the research, and how that then translates to the concept of trust as well, by involving the actual patients.
Yeah, I will start with the reflection right at the beginning is when we were doing the bigger D-part study, which was looking at adult patients dying in unit, nobody wanted to do this study. Like when we presented and pitched the idea, the researchers said, don't go near this. This is a sensitive time. Families are grieving. The ICU doctor said, no way you are getting next to our patients to ask them about and tell them we don't know how death occurs. Forget about that. It was only then when we met Heather and Heather's daughter who came to us and said, push through this resistance. This is important to me. She helped us create the consent form. She helped us present at Grand Rounds. She helped us with quotes that then we could send to our funding organizations so that they believed this was the right thing to do. She helped us create a pamphlet that we gave to ICU teams and their patients that was written in her words of what our study was about and how this would help them. I think that made a huge, huge deal. Then from there, Heather and Dawn review all our proposals. They help us write them. They review the feedback when we don't get our grants, and they help us write our manuscripts right from the beginning. And Heather's a school teacher, and these guys have a lot to add. right? Even if it's not the scientific component, they actually have more to add than many of our partners. Yeah.
Thanks, Sunny.
Sunny?
And we got a question here. Mohit Kahar.
So, in the last year or so, since you have been educating community, have you also seen like more so for liver, I guess, increased uptake of living donations, and people are more opting for that because when you communicate and educate the community, they also understand the organ scarcity and all that aspect of things.
Yeah.
Have there been increased sort of living donation options being offered,
Right.
and people more open to that idea?
So I'll answer this in two phases. One, I haven't looked. The reason I haven't looked is fundamentally, I don't want to overtly make that connection. I want to educate people to make sure these kids, especially because it's kids, to say, no, they're not just signing up for donation. That's not my goal. So I haven't looked and correlated that. However, that, like I said, nationally, we are saying what's our culture for donation? And we think that, especially in Ontario, our living donation is less active than some other jurisdictions like BC. They are far ahead of us for kidney and liver living donation. So we see that as an opportunity. And again, now we're trying to create a national structure that is focused on deceased donation, that now has a whole arm that says living donation. And in fact, I'd add in tissue donation will now be far more important to make sure that this is all balanced. So I do see that there will be an increase. There will be an increase.
We have another question here from Fouad Al-Naji in the audience.
Yeah, thanks, Sunny. You mentioned that when you withdraw a sustained therapy, there's the clock is ticking and the organs are slowly dying. I know some other jurisdictions they're looking at organ support specifically. Can you comment on that, and do you foresee that coming to Canada or Ontario?
Yes. So what I do is repeat the question. Fuad's asking, we're talking about time to death and how the organs are becoming ischemic and dying. Can we preserve those organs and reanimate them in better ways? And the answer is yes. So there's two ways to do this. There's three ways. One, we slow down the dying process when we remove the organ, ice and preservation solutions. Two is to put them on a pump, actually reperfuse them with solutions or blood in transport before transplanting at different temperatures. And in fact, Canada is one of the leaders in this type of science. For lung donation, they actually remove the lungs, put them in a bell jar, intubate them ex vivo, like they're just lungs and a trachea, and filter blood and antibiotics through them. And they've been doing that for dozens of years, which is world groundbreaking science. The third way, which is just starting, is called NRP, normothermic regional perfusion. And what that is after death has occurred in an operating room, the surgeons do an incision and rapidly try to remove the liver. Instead of doing that, which takes time because you want to save the vessels for transplant, is they cannulate and put these individuals on ECMO, a bypass machine that, though the individual's heart is stopped and the brain is stopped, that we recirculate the abdominal organs with blood flow in real time in the body. Then the surgeons can quickly reanimate blood flow to the organs after 2 hours, and then remove them carefully. We have not started this in Canada because we were worried that restarting circulation might restart circulation to the brain. And we are doing some research in London and now in Alberta that now is examining what blood flow is happening during this reanimation. And they've done about 10 what we call NRP donors I think the impact of the organs will be amazing, okay? But that we want to make sure that you stay dead during this process. In England, they had started the process and have stopped it. And in the UK, it's running Wild West. In Philadelphia, they did almost 400 donors this way last year. But there was a recent moratorium to say we've seen some reanimation with cerebral blood flow. So we are doing it the right way to create some science, some standardization, so that we're doing it the right way. For our prediction tool, it's still going to be useful because it probably costs about $100,000 to deploy that NRP machine. You need technicians, you need equipment. So again, if Toronto's going to use NRP, they want to be selective, especially in our environment. So if we could tell them, death's likely going to occur in 5 minutes, they don't need NRP. If death's going to hit 2 hours, yeah, they'll deploy NRP to try to recover those organs fast. So we think that this tool might actually be more helpful for financial costs in the future. And that's why actually a lot of our United States partners are looking at our decision aid for NRP actually. So great question. Again, I could have planted that.
Any other questions, audience, online? We have just a couple of minutes left. I don't see anybody's hands or comments. If not, then I would like to say a big thank you to Sunny for once again an awesome presentation, great conversation, excellent questions as always, exciting work ahead coming out of CHEO, and a big thank you to you, Sunny, again for the presentation. And then for those of you who looked up Sunny's sailing adventures, April Fools.
Oh! They really hook, line, and sinker. Thanks, everybody. Appreciate it. That was so good. It worked.